Okay, I think even I talk about is really look really advanced in treatment, but most of the treatment is still available mainly in Caucasians, in Western country, Europe and USA. I will say that in Asian country, so far we are currently available in only few countries. I think in many countries, pegylated interferon plus lipavirin still remain the mainstay of the hepatitis C treatment. As you can see in genotype 1, we can achieve SVR or cure rate about 70%. In genotype 2 and 3, it's still above 80 or 85%. I think in Southeast Asia, it may have to be after next 3 or 4 years until this many DAA become available in Thailand. It seems to be easy. The problem is all these DAA usually associated with the high cost of treatment. This can be a big barrier in, you know that in Southeast Asia, many countries had economic constraint. So with this treatment cost really high, it might still remain, some countries still go along with pegylated interferon plus lipavirin unless they can have a affordable and reasonable price of DAA. Having said that, that's why we will try to create strategy with suitable to our regions. I will say that in many countries who still have no sulfate available, we still start with pegylated interferon lipavirin, and then we check HCV RNA at week 4 of treatment. If they become undetectable with a sensitive method, we know that this is a strongest predictor of response. For example, even genotype 1 among Asians, if they achieve undetectable HCV at week 4, we define as RVR, rapid virological response. This can be associated with SVR or cure rate over 90%. And for those who had low viral load at baseline and had no unfavorable factor, we can shorten treatment duration to only 24 weeks. For genotype 2 again, if they achieve RVR, we might consider shorten treatment duration to 16 weeks and SVR rate still over 90%. But the patient must have no another unfavorable feature. So we can do this in Southeast Asia. But those who lack of RVR, yes, I will say that this patient require DAA therapy. You look at your patient. If your patient still have minimal fibrosis, we know that when they say state, we said it's a mean fibrosis. 0 is mean no fibrosis. F4 it means cirrhosis. If the patient have only minimal fibrosis like F0, F1, we know that the fibrosis change from 1 to 2, it takes almost 10 years. So in that patient, if they still have minimal fibrosis and lack of RVR, we might consider stop therapy and waiting for new DAA in order to improve the SVR. But in countries who have DAA available, for example, sulfapyravir, if they lack of RVR, I strongly recommend them to change to sulfapyravir-based therapy in order to improve. So this can be, you can see that our strategy quite different from Western. We have some specific issue, genotype, and also the economic constraint.